I would never say, oh, you know, you only lose one. I would say you lose somatosensation. Anytime on the exam, if I say you lose somatosensation, the assumption you will make is that you're losing both the anterolateral and the posterior column. Unless I specifically give you something that says, you lose pain sensation, you lose touch. Oh, touch. If I say touch, you've got to assume both, right? Okay. Ugh. Here's an interesting one. Symmetrical polyneuropathy. In general, symmetrical polyneuropathies are going to be the result of diabetes. There's almost no other way you can have this any other way. You can have losses that are occurring at or near the wrists. This is one of those scenarios, and you'll see this with diabetic neuropathy. People will lose sensation in their hands and feet. That's not uncommon, actually. Yeah?
So is that why they make diabetic patients, when they come in, take their socks off?
Right. Yes. Okay. There are two reasons for that. And this is all appropriate discussion, by the way. One is to do touch sensation, but the other is to look for loss of circulation, to look at the toes specifically. So yeah, that's what they're doing. They're checking that. It's easy to check the hands, but the feet, you got to make an effort. This is what they're in part looking for. Once you lose sensation to your feet, all hell can literally break loose, because you can end up with gangrene. Because usually the neuropathy is the result of some disruption in blood flow. So it's a lot of problems. Yeah. More likely, what you will see is one. You can also, this is one scenario. You can have discrete neuropathy as a result of trauma, mostly as a result of trauma, where you've damaged a nerve. And here's one example. Phantom limb. Grandma phantom limb? Anybody not familiar with that term? Okay, phantom limb is when you have typically a traumatic amputation, and the brain will get signals from nerves, somatosensory nerves, specifically posterior column somatosensory nerves, that say the hand's still there. Okay, it's people will tell you they can feel the hand, they know it's there, and everything is clearly not. Now, frequently associated with phantom limb, you get pain. It is not phantom pain, it is pain. Okay? And there are good reasons for this. With traumatic amputation, the nerves tend not to be cut smoothly, but they tend to be torn and jagged and ragged. And as a result of that, this is totally bizarre, they'll start growing. Each little jagged piece starts kind of growing. And they grow all of these free nerve endings. Now, you may not remember, but in general, free nerve endings are receptors. Most of the time, they're pain receptors. And remember, the signals are starting here, going to the brain. These nerves are still intact. The signals at the termini are saying, hey, I can still, your arm is moving, and therefore things are firing, and signals get to the brain and say, well, why don't you just pick that up? but you don't have a hand. I have a little bit of personal experience with this because my sister-in-law had a traumatic amputation of her hand. Took off half her thumb and the rest of her hand. Fortunately, it was her, one can say, fortunately, it was her non-dominant side. But 12 years later, she still has phantom hand and unresolved pain that cannot be treated with narcotics and other things, because what are you treating? It's crazy. So phantom limb is something you'll be dealing with clinically. You have to think about why should this happen? Okay, you haven't destroyed the signal from the wrist up. You've destroyed the signal from the wrist down. Okay, or the receptors are gone, but you can still signal. In a lot of respects, with phantom limb and phantom pain, it's very similar to referred pain. We never really taught much about referred pain. But it's like, why should you have a heart attack and have pain in your arm or pain in your jaw? Is your heart anywhere near your jaw? No, it's not. Near your arm? No. You got shooting pain going down your arm? No. You got any real pain in your arm? Is there a problem in your arm? No, there isn't. But the signal's coming out from your heart. Bundle in with, you remember this brachial plexus thing here? These signals are coming in from all over the place. Your spine, you have other plexes here, but they come in your spine. They're coming on up. You've got all these signals coming in from the brachial plexus. They tie together and they bundle together as groups of nerves, and the signal spills over. So it's signal spilling. Yeah. So this one is kind of odd and weird. Isolated nerve lesions. It's showing you a very bizarre scenario here. All right? So we have a nerve lesion somewhere in here, and you're losing this. This is a very specific dermatome, by the way, that you've lost here. Okay? Dermatome. You remember talking about dermatomes? They're somatosensory, and they're somatosensory to the peripheral nerve signal. So, we could draw this anywhere you wanted. This just happened to be one example. Okay, so isolated nerve damage. What you are going to see is loss of sensation distal to the damage. So the loss of sensation has to be distal to the damage, not proximal to the damage. Because everything here is still communicating with the brain. So the signal, your receptors are here. The signal comes up, gets here, can't go anywhere, is done. Does that make sense? Once again, with this, you can take anything you want and lay it out along here. And you can say, oh, if I have damage here, what do I lose? Et cetera, et cetera. If I have damage here, what do I lose? Versus damage here, what do I lose? And it's a good exercise for you to try that. Now, these are all nerve damages and cortical damage that we've been looking at so far. But I want to go back to the one that had the cortical damage in it. Because we could have discrete damage here. If I have discrete damage here, I'm only going to lose, stuff to the face. So we can have discrete damage in the cortex and lose discrete areas. Yeah, I don't know why the textbook doesn't show you more of these, but so you have a central bleed here. We could lose everything to both legs, and we could have loss of sensation to both legs. So these things can happen. That making some sense? Cool. All right. Now, damage to the cord is a little more interesting, bizarre. You know, all sorts of things can happen. And with damage to the cord, they're actually starting to bring in the combo, where you're not just looking at somatosensory damage and somatosensory loss, but you're also looking at motor loss. Transverse cord. Okay? Transverse cord lesions literally mean you are doing the equivalent of cutting the cord. You are just taking the cord, every tract in the cord at some level is being damaged. Typically, you can see this as a result of trauma. On occasion, as a result of a tumor that would affect the whole cord. Multiple sclerosis. This transverse cord loss in the lower legs is actually quite common in later MS, long-term MS. Transverse myelitis. So we have issues dealing with inflammation of myelin. We have, once again, transverse issues. Every time you see the term transverse, it applies to the entire cord. So with this scenario, we have the entire cord being affected. We're losing the posterior columns, we're losing motor columns, we're losing the anterolateral column from the mid-low torso down, you have nothing. So what would we call a person that has this problem? What would we call their loss? I'm sorry?
Paraplegia.
It's paraplegia in its entirety. They have no motor, they have no sensation.
Why is it just the legs?
Oh, because it would be low cord damage.
Okay.
Yeah, that's it.
So if it was
Okay.
higher up, it would
The higher it is, you could, yeah. If we had done this at the level of the neck, it would be it would be full quadruped. Yes. Okay, so here we have unilateral hemichord lesion. You lose everything on one side. Trauma, MS, and tumors, typically. This one is pretty unusual. Once again, we're looking at somebody that has trauma at the level of loss. And two weird things should jump out at you. Number one, on one side, you have a loss of vibration, position, and motor. On the other side, you have a loss of pain and temperature. And then we have this little weird piece here. That little weird piece is due, excuse me, to the way some of the peripheral nerves work in the torso. We haven't looked at a lot of those, so for right now, just hang on to that. It really is nice having this in association with that, this drawing, because it really shows you exactly what columns you're knocking out. So with all of this, it comes in, it synapses, it goes up. With this, it comes in, synapses, crosses over, and goes up, so that you're losing it. Okay, still?